Welcome to Board Pearls. This is episode 1 of 5 of the GI infections chapter in the Special Populations and Acute or Supportive Care module. In this episode, we cover Clostridioides difficile from diagnosis through the first episode and fulminant disease, the two-step diagnostic algorithm of NAAT plus toxin EIA, severity stratification that guides treatment, fidaxomicin as first line with oral vancomycin as the established alternative, and fulminant C. diff with IV metronidazole plus oral vancomycin plus surgical consult. C. diff is a disease where the modern algorithm is built around two competing problems. The first is that the boards used to teach metronidazole and vancomycin as the answer, and both of those defaults have moved. The second is that asymptomatic colonization is common, so the wrong test in the wrong patient generates positive results that drive unnecessary treatment. Everything in this chapter reduces to those two problems. Diagnosis is built to separate active disease from colonization. Treatment is built around getting the right drug to the colonic lumen at the right concentration for the right duration. Recurrence is the dominant failure mode, and the modern toolkit was built specifically to address it. Start with who gets C. diff and how it presents. The disease typically follows antibiotic exposure within the prior 8 to 12 weeks, with clindamycin, fluoroquinolones, third-generation cephalosporins, and broad-spectrum penicillins carrying the highest risk. The mechanism is that those antibiotics decimate the colonic anaerobes that normally outcompete C. diff. Once the commensal community collapses, C. diff spores germinate, the vegetative cells expand, and toxin production starts. The other risk factors stack on top of that antibiotic exposure. Advanced age, hospitalization or long-term care residence, proton pump inhibitor use, inflammatory bowel disease, immunosuppression, malignancy, and prior CDI. Each of those raises risk modestly. The dominant factor in almost every stem will be the antibiotic, and the highest yield single agent in stems is clindamycin because it carries up to a 20-fold risk increase. When a stem lists clindamycin 5 weeks ago, plus age over 65, plus chronic PPI, the strongest contributor is clindamycin. The age and the PPI add a couple of fold each. The clindamycin adds 20. Presentation is watery diarrhea, mucus in stool, abdominal cramping, low-grade fever, and leukocytosis. Gross blood is unusual, and that absence helps distinguish it from inflammatory bowel disease or invasive bacterial enterocolitis. The variant worth knowing is the right-sided cecal predominant pattern, which presents as fever of unknown origin with right lower quadrant pain and leukocytosis, sometimes with little or no diarrhea. That stem looks like appendicitis or terminal ileitis, but the underlying disease is C. diff in the cecum. Pseudomembranous colitis on endoscopy, the yellow plaques with abrupt transition zones, is essentially diagnostic when seen. Now the diagnostic algorithm, which is where most of the board points live. The problem the algorithm solves is that the available assays trade sensitivity for specificity in opposite directions, and no single test gets both. NAAT for the toxin genes TCDA and TCDB is highly sensitive for the organism, but it detects the gene, not active toxin production. A patient with asymptomatic C. diff colonization in the colon will have a positive NAAT and not have disease. Glutamate dehydrogenase antigen is similarly sensitive for the organism and similarly cannot distinguish colonization from active disease. Toxin enzyme immunoassay, the EIA, is specific for active toxin production and therefore for active disease, but its sensitivity is limited. The two-step algorithm exploits the asymmetry. Screen with the sensitive test, NAAT or GDH, to rule out the organism in the colon. Confirm with the specific test, toxin EIA, to establish that the organism is producing toxin. Concordant positives establish CDI. Concordant negatives effectively exclude it. The discordant result, NAAT positive and toxin EIA negative, is where the teaching lives. That pattern most often represents colonization rather than active disease, especially in a patient with low pretest probability or another explanation for diarrhea. Treating those patients drives overdiagnosis without clinical benefit. The right move on that discordant result is clinical correlation, not reflexive treatment. The corollary to the algorithm is who gets tested in the first place. Testing requires high pretest probability. 3 or more unexplained watery stools per day in a patient not on laxatives with classic risk factors. Testing for stools or asymptomatic patients is a setup for false positive treatment cascades. The same logic explains why test of cure is not recommended after treatment. Up to 50% of treated patients with resolved symptoms still carry detectable nucleic acid in stool from dead organisms or persistent asymptomatic colonization. The patient who completed fidaxomicin feels well and asks for a clearance test before visiting elderly parents, gets reassurance and hand hygiene counseling. The right answer is to decline the test because a positive NAAT in that setting is colonization, and treating colonization to clear it perpetuates the cycle. Post-infection irritable bowel syndrome is the other reason follow-up testing misleads. About a quarter of patients have persistent functional GI symptoms after CDI clearance. A NAAT done on those symptoms will come back positive for the same dead DNA reason and prompt unnecessary retreatment of recurrence that isn't there. Severity stratification is the next discriminator, and it drives treatment intensity. Non-severe disease has a white blood cell count below 15,000 and a serum creatinine at or below 1.5. Severe disease meets either threshold, white count at or above 15,000, or creatinine at or above 1.5. Fulminant disease adds hypotension or shock, ileus, or megacolon. Recurrent disease is recurrence within 8 weeks of completed therapy. The reason those exact thresholds matter is that fulminant features change the regimen and bring surgery into the conversation at presentation rather than after medical failure. A patient with a white count of 24,000, a creatinine of 2.4, hypotension at 88/54, lactic acidosis, and pancolitis on CT is not severe non-fulminant. That patient is fulminant because hypotension is present and the management changes immediately. Now treatment for the first episode in non-fulminant disease. The first-line agent is fidaxomicin 200 mg orally twice daily for 10 days. Oral vancomycin 125 mg 4 times daily for 10 days is the acceptable alternative when fidaxomicin is unavailable or cost-prohibitive. The shift from vancomycin to fidaxomicin came from a pivotal trial in which cure rates were similar, but sustained recurrence dropped substantially with fidaxomicin. The mechanism is that fidaxomicin has a narrow spectrum that spares Bacteroides and other commensal flora, so the microbiome recovers and resists recolonization by germinating spores. Vancomycin's broader anti-gram-positive activity damages more of the commensal community and leaves more open ecological niche for relapse. Oral vancomycin works in C. diff for one reason. It is essentially not absorbed from the gut, so the entire administered dose reaches the colonic lumen at therapeutic concentration. The same property explains the most tested negative rule in this disease. Intravenous vancomycin is never appropriate in C. diff because it does not reach the colonic lumen at therapeutic concentration. The drug has to be where the bug is, and where the bug is the colonic lumen. Anytime a stem offers IV vancomycin as the answer to C. diff, the answer is wrong. Metronidazole has fallen to third place, and the reason is mechanistic. Oral metronidazole is rapidly and almost completely absorbed from the small bowel into the systemic circulation. Its colonic luminal concentration depends on biliary excretion and on inflammatory secretion across an inflamed mucosa. As the colitis resolves, the inflammatory secretion drops, and the drug concentration in the lumen falls in parallel. Metronidazole is most active in the colon when the colitis is worst and least active as healing progresses, which is the opposite of what cure requires. Trial data confirm the clinical effect, with vancomycin outperforming metronidazole overall, and the gap was widest in severe disease. 2 additional safety constraints sit on top of that mechanism. Metronidazole carries an FDA boxed warning for carcinogenicity, based on the carcinogenicity demonstrated in mice and rats. That is the boxed warning. Separately, prolonged use is associated with peripheral neuropathy and other neurotoxicity, which is a labeled warning rather than the boxed warning. The two are often conflated, and they are not the same. The boxed warning is the carcinogenicity. The neurotoxicity is real and is a constraint on prolonged or repeated courses, but it lives in the warning section. Either way, metronidazole is reserved for the lowest risk patients only when neither fidaxomicin nor vancomycin is available, at 500 mg orally 3 times daily for 10 days. Pregnancy is the one place where vancomycin moves back to first line over fidaxomicin. The reasoning is data, not mechanism. Vancomycin has decades of pregnancy safety data because of its negligible systemic absorption, so fetal exposure is essentially zero. Fidaxomicin's pregnancy data are limited. In a pregnant patient with non-severe CDI, the answer is oral vancomycin 125 milligrams 4 times daily for 10 days. Metronidazole is not chosen here even though it is category B, because the efficacy gap persists in pregnant patients, and vancomycin is both effective and safe. The other adjunct that belongs in initial treatment is stopping the inciting antibiotic where possible. If the patient is on day 6 of piperacillin tazobactam for a pneumonia that has been afebrile for 48 hours with a clearing infiltrate, the stewardship answer and the C. diff answer converge on stopping the piperacillin tazobactam. Continuing broad-spectrum antibiotic coverage while treating C. diff perpetuates the dysbiosis that drives the disease. Switching the inciting antibiotic to another broad-spectrum agent, especially a fluoroquinolone or a third-generation cephalosporin, preserves the problem rather than fixing it. Discontinuation of any non-essential antibiotic is part of CDI treatment, not separate from it. Now, fulminant disease. The criteria are severe disease plus hypotension or shock, ileus, or megacolon. The regimen has 3 components and a parallel decision tree about surgery. The antimicrobials are high-dose oral vancomycin 500 milligrams every 6 hours, plus intravenous metronidazole 500 milligrams every 8 hours. When ileus prevents oral delivery, vancomycin 500 milligrams and 100 milliliters of saline per rectum every 6 hours is added, so the drug still reaches the colonic lumen from below. Walk through why this regimen is built the way it is. The high-dose oral vancomycin is the lumen side mainstay, because at 500 milligrams every 6 hours, the colonic concentration is maximized in a colon that may have impaired transit. The rectal route is added when ileus prevents oral delivery, because the only thing that matters is the drug reaching the lumen, and ileus disconnects the oral route from the colon. The IV metronidazole is the adjunct that addresses the systemic component, the bacteremia risk, and the inflammatory load through the inflamed mucosa, where systemic metronidazole does reach the wall. The whole regimen is dual route on vancomycin plus systemic metronidazole. 2 negative regimens are worth saying out loud because they appear as distractors. IV vancomycin plus oral metronidazole is wrong on both routes. IV vancomycin does not reach the lumen, and oral metronidazole is the wrong route for the systemic component in fulminant disease. Fidaxomicin is not first line for fulminant disease, and adding broad-spectrum coverage like ciprofloxacin worsens dysbiosis without addressing C. diff. The fulminant regimen is the high-dose vancomycin plus IV metronidazole. Surgical consultation is engaged at presentation in fulminant disease, not after medical failure. The thresholds for operating are perforation, refractory hemorrhage, megacolon with progressive distension, or persistent sepsis despite optimal medical therapy. The 2 surgical options reflect a trade-off between definitive source control and organ preservation. Subtotal colectomy with endoleostomy removes the toxin source entirely and is the operation for the sickest patients with established necrosis or perforation. Diverting loop ileostomy with intraoperative colonic lavage and antegrade vancomycin instillation preserves the colon. It diverts the fecal stream while delivering high-concentration vancomycin from above to the colonic lumen, and it is the option for the more stable patient with intact colonic anatomy. The decision is between definitive resection in the unstable patient with high mortality and organ-preserving lavage in the more stable patient. Pull the first half together. Diagnosis is built around the colonization versus active disease distinction, which is why the algorithm is a sensitive screen plus a specific confirm, and why test of cure does more harm than good. First episode treatment is built around getting drug to the colonic lumen at the right concentration, which is why oral fidaxomicin and oral vancomycin work, while IV vancomycin and rapidly absorbed oral metronidazole fall down, with fidaxomicin first line for its recurrence advantage and vancomycin first line in pregnancy on safety data. And fulminant disease adds the dual-route, dual-agent regimen of high-dose vancomycin plus IV metronidazole with surgery engaged at presentation, because the patient is now dying and the colon may not be passing oral drug. The next episode takes the dominant failure mode of C. diff, recurrence, and the toolkit built specifically around the spore germination cycle that drives it, extended pulse fidaxomicin and tapered pulse vancomycin, the host immunity layer of bezlotoxumab, and the microbiome-restoring live biotherapeutic products that replaced uncontrolled fecal transplant. For the full chapter, the practice vignettes, and the topic-tagged question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 1 of 5 of chapter 33, and I'll see you in the next one.